Talquetamab is actually one of our new bispecific antibodies that goes after a different target. So far we've talked about BCMA, CAR Ts and BCMA bispecifics. But now in myeloma, we've actually found new targets, which is fantastic because we can attack those myeloma cells in a different way. So talquetamab actually goes after the antigen called GPRC5D. It's a whole alphabet soup. But this target is actually on myeloma cells almost 100%, especially those people who have had, treated myeloma. But we also see it sometimes in smoldering myeloma as well. Yeah, so GPRC5D is actually a great target in that it's not on any major the organs in our body, so that we worry that the bispecifics, when they're activating our T cells and bringing them into the myeloma cell and kind of putting it next to that, we don't want it to go to the other other clinically relevant organs. And so the nice thing is that it's not on the heart or anywhere else. However, it is on hair follicles, and some of the side effects that we see are related to that. Some of the side effects because of that GPRC5D being on hair follicles, it's not so much hair loss, but what we've seen is about a third of patients on the trial have gotten skin rashes. A few have gotten grade 3 skin rash, which means that you have to sort of hold the drug, wait till it gets better, and then restart. The good news is when they restart, patients don't have it anymore. They're able to figure out a way to keep that from happening. Another specific for GPRC5D we've seen toxicity is dysgeusia or taste changes. So there have been patients who aren't able to taste the same way. So that's been something new. For most patients, it's been relatively mild, but something that we're keeping an eye on. And then nails. So there's been some patients with a lot of nail changes. Again, nothing fatal or causes major morbidity, but again, something we're keeping a close eye on. Mostly it's been just supportive medications. So sometimes if it's really bad, you can do steroid creams, but usually it's things like antihistamines, things like that to see if it goes away. But there's not a single way yet that we've done, but most of the time it's just holding their drug if it's really bad and then bringing it back in after. The bispecifics in general, being off the shelf, is sort of, it's a biologic because it's still waking up your T cells to help kill the myeloma. But unlike CAR Ts, where you have to take the T cells out, put a new receptor in, grow them, and then give them back, this is off the shelf. I can order it and actually just infuse it like we do for other therapies in myeloma. So other monoclonal antibodies or drug conjugates. We're kind of getting back to those types of therapies where I don't have to wait 4 to 5 weeks to make something. And so the advantage there is that we don't have, if someone has really bad disease, we don't have to wait for a long period to actually start the treatment. Talquetamab is actually sub-Q, which is fantastic, at least in our history. When we have patients who have sub-Q drugs, that takes less time for the most part. And for their study, it's not approved yet, but on their study, they've looked at two main doses that they think are probably they're gonna move forward with. One is a dose that's given every week, sub-Q, and that's for 3-week cycles. And then the other one is a higher dose of 800 milligrams that's given every 2 weeks for a 4-week cycle. And that's what they're trying to see, that can they give less therapy over time and still get maybe a higher dose, but still get the same response so that patients can get less drug. So it's a set dose, but there is something called priming that we do. And so basically, patients will get a really small dose initially, and they did it two different ways. So they get a small dose the first week, then a slightly larger dose, but still a very small dose, and then you get the full dose. So you can either get two priming doses or one, and that's really what they were studying. And for most of these studies, the two priming doses tends to work better, that we can get a higher dose of the drug in and get a better response and less toxicity. Priming and step-up dosing are similar. And basically, when you give something like a bispecific, if you give a lot at once, their T cells are just going to go crazy. They're going to have a party. They're going to, get activated, and they're going to start killing all that myeloma. And when that happens, you can get really high levels of cytokine release syndrome. So the fevers, the oxygenation that can go up and down, blood pressure issues that can happen. And it's because you have so much inflammation all at once. When you do the step-up dosing, you're doing a little bit at a time so that your T cells are slowly waking up. And then once they're already primed, then you give the bigger dose so they don't have as big of a party. Yeah, so I think for bispecifics, that the risk of CRS is still there. Thankfully, it's low grade, grade 1, 2, which we usually treat with just, acetaminophen, sometimes tocilizumab to help knock that CRS down. But because that's the highest risk is in the first cycle, all of these newer generation bispecifics against other antigens are also being administered in the hospital first. So the first dose of cycle 1 is usually about 48 to 72 hours in the hospital. And then once you don't have any more CRS, the rest is all outpatient. So with TAL, I think they used acetaminophen and diphenhydramine and then steroids, actually, corticosteroids. However, with immune therapies, we know we don't want to do steroids for a long time because it can kill your T cells and your NK cells, the things we're trying to use to kill the myeloma. So for TAL, I think after the first cycle, they don't use the steroids anymore, but they continue with the acetaminophen and the diphenhydramine just to make sure you don't get infusion reactions, things like that. Talquetamab CRS rates are about 70%, mid 70s. Again, mostly grade 1, a few grade 2, and I think only one grade 3. So fevers, that's the main thing that we see. There are some patients that had, a little bit of a drop in their blood pressure, so they needed fluids. And they had maybe a little bit of oxygen that they needed. So those are the patients that are grade 2, and that's usually when we use tocilizumab. So tocilizumab is an anti-IL-6 that we've used for lots of different things. And again, it works here because CRS is still similar in all these different products, and it's sort of a byproduct of these T cells getting activated and killing that myeloma. So we knock that cytokine down, IL-6, which helps kind of decrease all the inflammation. The other side effects, again, mostly are blood counts. So your white count, your hemoglobin, your platelets, they're not very severe, but we are monitoring them pretty closely after you've started. And then we might have to, usually we don't have to give transfusions, but again, if it gets really low, we hold the drug. But so far, people have done really, really well with it. And then the other ones that are specific really are the skin, nail, and taste changes. So it's a little bit earlier for these studies, but hypogammaglobulinemia is something we see in a lot of treatments for relapse refractory myeloma, partly because a lot of therapies have already given patients that, and then you add another immunotherapy. And really, the hypogammaglobulinemia happens when we kill both the bad and the good plasma cells, so the myeloma cells plus the plasma cells. And these targets are also on good plasma cells. So again, there's definitely a risk for hypogammaglobulinemia, which puts you at a higher risk of infections. So, I think about a third of patients on this trial had infections, just like with a lot of other immune therapies. So it's just really important that if someone has a fever, that it could be CRS, it could be an infection. So this is why, we monitor and put people on antibiotics, make sure we work that up. And for hypogammaglobulinemia, if we need to give IVIG, most of our patients are getting that with pretty much all of these bispecifics. So right now it's monotherapy. However, it's not FDA approved. So again, it'll be something that hopefully will get approved in the next couple of years. But I know that they're working on combination studies as well with daratumumab and other immune therapies. So the clinical trial for talquetamab has been a phase 1/2, and mostly we've seen the phase 1 data. So they're trying to find the right dose. So they slowly go up on the dose. They're trying to find the right dose that doesn't cause too much toxicity, but has the best responses. And so far we've seen data for those first patients on the phase 1 trial, and both regimens. So the patients who got the lower dose of 405 milligrams once a week, as well as the ones who got the 805 every other week, have had great responses. So 66 to 70% basically in both groups. So pretty phenomenal. And patients who had BCMA therapy before were allowed to be on this trial. And they had about 25% or so of BCMA treated patients, which is fantastic to know that we have other antigens that we can go after. Most of these patients had had all other therapies already that they could either tolerate or, that we have for myeloma. So they were pretty relapse refractory, multiple lines of therapy. Your ECOG performance status had to be good, 0 to 1, just to make sure you could get through CRS. But really, no other major change in compared to other trials. I will say we think about penta-refractory patients as a big group of patients that have resistant disease. And this trial, I think, had about a third of their patients were penta-refractory.